One of the biggest trends impacting healthcare today is our aging population, called the Silver Tsunami. The statistics are staggering. In the next 25 years, the number of people older than 65 will double. Baby boomers, those born from 1946 to 1964, are aging into Medicare at a rate of 10,000 people a day. According to the U.S. Census Bureau, there are 75.4 million baby boomers in America. By 2020, for the first time in history, the number of older people will outnumber the number of children younger than age 5. Not only are people living longer, they are often living with chronic health conditions that need specialized care. The Silver Tsunami has major ramifications for healthcare and the sheer volume of patients who may eventually need long-term care. To handle this wave of individuals across the healthcare spectrum, there is a renewed focus to lower the costs to alternative medicine, providing quality care to patients and aging in place. And that is where the VNA and Hospice of the Southwest region comes in. The challenging of meeting the needs and rapidly aging population is significant across the healthcare spectrum. Experts are looking for ways to provide excellent care at a lower cost. VNAs have moved into the forefront as experts in post-acute care. Today, we have as our guests experts from the VNA and Hospice of the Southwest region who work with patients and families in providing expert care and advice. Welcome to the show. I have with us today Patti Kent, who is a transitional care coordinator and a registered nurse, and Beth Wilson, who is our manager of home care for nursing and also a registered nurse. Welcome to the show, ladies.
Thank you.
So what is the role that VNAs play in the healthcare system?
Well, I think we have to understand that hospitals, skilled nursing facilities, physicians, nurse practitioners, physician's assistants, and other primary care providers do important work in clinical settings and in their office practices. But what really happens for patients when they go home is just as important. And this is where the visiting nurses can come in and play a vital and important role in maintaining people at home to be as healthy as possible for as long as possible.
Okay, and how does that actually work? I mean,
it works with working with our families and the patients, the providers, whether it's a referral from the hospital or a nursing home. We look at trying to come up with a plan to make our patients healthy, safe at home, and we coordinate that care with the providers, with the families and the patient. Our goal is to make them healthy and as independent as possible in their homes today.
And so when that happens, I mean, so this is, I mean, in part, what we're talking about a little bit today is how home health care fits into the larger scheme of the healthcare system itself that is in this country. That includes, obviously, hospitals and, like you were saying, Beth, and physicians and the like. So when a person is in, let's say, a hospital, how do they get discharged from the hospital, and then what happens? What happens to the patient, and how does the VNA get involved in that?
We, as a liaison at the Rutland Hospital, I would meet the patient, the families, work with the case manager, dischargers, and come up with a plan as to what services they might need. The most important thing is to interview the patient and find out what their needs are, what their goals are, and what we can do to help them sustain those goals in their home. And then from there we get the needed paperwork to process the referral. And then usually within 24 to 48 hours we go in and see the patient.
And my guess would be that it is probably fairly simple for someone to get home health care services once they make contact with us, right?
Well, you know, we have to always be mindful of regulatory requirements which govern home care services. Our job at the visiting nurses is when we receive referrals from the facilities, physicians, communities, family members who might call, neighbors who might call, and try to determine how we can help people in the community. Our job is to reach out to the primary care provider, obtain the information that we have to obtain, and then ensure that we are following the regulatory requirements that govern our practice. That sounds like a lot of work on our end, but we're very well seasoned at it. We're very accustomed to dealing with those types of issues. So sometimes all we need is, a call from someone, whether it be the doctor or a family member, and saying, I've got this person in my life and they're having problems. How can you help us?
Yep. And to a certain extent, and again, I think it is important for us to stay focused on the fact that, and we'll talk about the insurances and things like that in a little bit, but I think it is important to realize that home health care is a regulated we are regulated by both the state and federal government. So there are standards to which we are held to, and there are also eligibility requirements for patients to receive services through our agency if Medicare, Medicaid, private insurance is going to be the payer.
That is correct. People always are interested in what services am I going to receive in my home, and what will it cost me? Yeah. So our responsibility as the visiting nurses is to determine that cost structure. Most of the patients that we serve are Medicare eligible, and Medicare or managed Medicare programs generally cover those services at 100%. We do have patients who receive Medicaid as their insurance coverage, and that's also covered at 100%. Private insurance is a little different. It varies from insurance carrier to insurance carrier, and we work with those insurances to ensure that we have coverage for the services and we minimize any cost for the patients out of pocket. We also, from time to time, will get referrals for people who have absolutely no insurance coverage. Right. We have never at the visiting nurses refused services to a patient based on their ability or inability to pay. Yep. When people in this community go to their polls every year and they vote to give monies to the visiting nurses, it is for those people in the community that have no insurance coverage so that we can provide services to anyone in need regardless of their ability to pay. So we have a very good structure in our organization to be able to manage wisely the dollars that we are given to help people stay at home and to keep them in the best possible health.
And I think that is important because part of what we do once we're contacted, and again, you said it could be the hospital, it could be a physician, but it could even just be a family member that calls up and says, hey, you know what, I think my mom, whatever. We do the legwork to determine all of that stuff, do we not? And that's...
Yes, and that also takes the burden off the family and the patient, that they don't have to think about, oh, what do I have to give you to get the service started? That's our job. We know how to do it. And then we just move forward. Our goal, again, is to find out what their needs are and how we can sustain them at home so that they can stay there safely. And the process goes really smooth, so it's a nice process.
And that's something, you know, your work here, Patti, is both in intake and we call you a transitional care coordinator, because you also work here and at the hospital as a liaison. A big piece of the work that's done in intake and in the hospital is that initial point of contact, that initial discovery of information and stuff like that, is it not?
Yes, it is. We usually get heads up from a case manager that this patient is coming home and they might need this service. Could you go in and, you know, meet with the family and the patient and, you know, just go over some things with them and see if there's anything else that we might need to order for them. Occasionally, you know, I'll go in and they might need to have a social work added. They may need to have a nutritionist, speech therapy, OT, PT added to, you know, therapies for this patient. So we look at that and come up collaboratively with the case managers and the physician to get those orders as we need them.
You know, we talk a lot about, and I again, obviously, you know, when somebody is getting out of the hospital, and I don't know, maybe it is obvious, maybe it's not, I'm not sure, but you know, the question gets asked a lot, you know, sort of when is the right time for home health care? And there probably isn't a single answer to that question, is there?
You know, it's hard to determine an answer that would cover every individual you might encounter.
Yeah.
And people vary in their ability to function independently at home. You know, if you think about it, from the day we're born, we are trained and raised to be self-sufficient and independent in managing our activities of daily living and in managing our lives to a certain extent. As we age, we often see that we start to develop difficulties with managing things that prior to had not really been an issue.
Yeah.
Maybe I've got some really bad arthritis and I've gotten to where I can't dress myself and wear the kind of clothing that I want to wear. Maybe I'm starting to get weaker and starting to have some falls at my home that I hadn't had previously. Perhaps I've developed some forgetfulness and some memory issues and I'm forgetting to take my medications. These are all things that indicate I'm starting to struggle maintaining myself at home at the level of independence I had at one time.
Right.
These are the kind of things that make you think, what can I do? What can be done for someone who's starting to face these struggles? This is where the visiting nurses come in. And it's very simple for us to go out to the home once we've met the requirements of getting approval from the physician or nurse practitioner or physician's assistant to come out into your home and evaluate what are you struggling with, and then to develop strategies and techniques with various team members, whether it be nursing and combinations of physical and occupational therapy, social work. All these people work together collaboratively with the primary care physician to try to put things in place to address these difficulties that are impacting how patients function on a daily basis.
Yeah, and again, I think, you know, one of the things that strikes me as being somewhat of a common thread with a lot of folks who end up with home health care services is exactly what you're just saying, that you know, maybe it's sort of easier to get your head around it when you're talking about somebody who just had their knees replaced, or they just had hip surgery, or they had a heart attack or something like that, and so they come home and they need that skilled nursing or skilled therapy services in their home. But a lot of times it's a bit more subtle than that, is it not? A lot of times it's just more like, you know, I noticed that mom or grandma or grandpa are struggling. They don't seem to be changing their clothes lately,
or forgetting to take their medications too, or you know, maybe their daughter pre-poured the med box and they come in and say, mom didn't take her medicine today.
Yeah.
What do I do?
Yeah.
You know, that's a good time to call.
Right.
Right.
And I think you make a very valid point. It's sometimes very easy to know that home care is appropriate. I've had a recent hospital stay. I've recently been discharged from a long-term care facility where I was receiving services. Those things are pretty much crystal clear. What gets to be a little bit more foggy for folks is those certain situations where you just see people getting worse and you can't necessarily pinpoint a reason, but you see that people are starting to struggle and people are starting to fail. So what I've always thought might be a good approach to that was, if that was my parent, take them to the doctor and say, you know, I've noticed that mother can't do A, B, and C anymore, or she's struggling with things she didn't struggle with before. And would you be willing to consider sending the visiting nurses into the home so they can help us figure out what she's struggling with, why she's struggling the way she is, and then what can be done about it to make these things easier or better.
Yeah.
It's not unusual that we might get a referral from the community provider that orders one service. I have a patient who came in today, for example, they've got a wound on their leg. So the nurse goes in and finds, yes, indeed, there's a wound, but there's also other problems now. I found out you fell 3 times last week, so clearly you need some physical therapy.
Right.
I find out on my evaluation that you can't get in the bathtub and the shower anymore and you're struggling to fix your breakfast in the morning. So there's a need for occupational therapy. So sometimes, and more often than not, when we go out and do that initial evaluation, we find a lot more than what we thought we might find going in. And that is our job, to look at things comprehensively, to determine everything that's going on in the home so we can try to come up with strategies with the patient, family, and primary care provider that can try to make a difference in what the problems are that we found.
And you know, I really think that when people are thinking about home health care, the obvious points of intersection are clear, but I think a subtext of what you just said is that even if on the surface the family member seems to be struggling with one particular thing, but because of that conversation with the physician, now there was a call to the agency, to the VNA, to say, hey, listen, you know, could you please come out and check whatever? When that nurse or therapist goes out, there's actually a comprehensive assessment that's done of that patient. And that does sometimes lead to a more comprehensive set of care for that patient, does it not?
Well, I think it's fair to say that there's rarely one single solitary problem for patients that we see in home care. There is usually a group of problems that are identified by that initial observation and intake and assessment visit that is made by the admitting clinician. Sometimes we get a lot of information from the referral source that gives us a good idea of what to expect when you come into the home. Oftentimes, we don't get as much information because it is not known.
Right.
I know that it's not unusual for us to go in and when talking to people, you know, how are you managing your food? Well, I can't cook anymore because I can't stand up long enough to cook.
Yep.
So now I'm having to, you know, heat frozen foods and it's not within my diet and I'm starting to have problems. So there's a whole litany of things that are uncovered, not just in the initial visit, but in the subsequent visits as we continue to go back again and reevaluate what's happening in patients' homes. So that's a constant, ongoing assessment and reassessment to determine what's happening with these people in their homes and what are they struggling with that we can provide some kind of assistance for.
And, you know, I think one of the things that strikes me as being a real benefit, especially at that first visit, or even, like you said, even some of the subsequent ones, is that folks often are reticent to tell their kids or something like that. They don't want to worry them. They don't want it to really know, or maybe just uncomfortable. But if a nurse or a therapist is actually in my house and now I've had a chance to talk to that person a couple of times, all of a sudden then you start to find out a little bit more about what's actually going on in that person's life. And, you know, it's amazing because if even regardless of whether or not it was a nurse or a therapist that does that admission, if that nurse or therapist identifies other needs, those other disciplines can get into the home, and that's also pretty easy, or is it not?
Yes, actually, they just need to let us know. We'll call the physician to get an order for a therapist to go in. Could be a home care aide for bathing if they're weak and can't get in the shower alone. So it's just a matter of giving us a communication call and letting us know what the needs are, and then it's a very easy process to go in and call the physician to get the orders. And the doctors are more than willing to support this. They want their patients to be healthier and stay home and be safer. So it's less cost to the population and Medicare, and less hospitalizations too. So,
and that really is an important piece of this is, pardon me, is that physicians have as much of a vested interest to a certain extent as the patient does of being able to stay healthy and independent in their homes. And really, you know, VNA and Hospice Southwest Region, we are experts at being able to keep people in their homes, and the client themselves has a pretty important role in that as well, do they not?
Well, I think, generally speaking, the only really good and happy time to go into a hospital is for the birth of a child.
I agree.
That is a wonderful time in people's lives. We
That's
look
the happy
forward
flow.
to it and with great anticipation. And it's a happy reason to go.
Yes.
Short of the birth of a child, most people have no real desire to go into a hospital. It's not a good thing. It's not a happy time.
Right.
So anything that can be done in the community, whether it be through an appointment with a primary care provider like a physician, physician's assistant, nurse practitioner, and or the assistance of the visiting nurses and their staff, any of those things that can be done in the community to keep people away from a hospital is in the interest of the entire community, both the medical community and the private community. Patients don't want to be in hospitals. Patients' families don't want them to be in hospitals. Right. So anything that we can do in the community to avoid that serves a lot of positive purposes.
And you know, I think there's a statistic I've heard a few times that says something like 92% of all people, if they had a choice of where they'd actually like to receive healthcare services, they say in their home. Oh, yeah. We realize that the percentage that actually end up getting it is lower than that, but I mean, but it is an overwhelming majority of folks.
People are happier at home. They're generally healthier if they can stay at home. Yeah. And I know personally I would want to have services rendered to me in my home if it was ever at all an option when the time came for that need to be met.
So I'm going to go back a little bit and then come back in a moment to this conversation. But so really, because I want to try to focus a little bit or refocus on the transition from I'm not on home healthcare services yet to I am, and then that first visit, because that first visit really is an important part of it, right?
Key. Yes.
I mean, so a referral can come from
anywhere, and we have a toll-free number that you can call. It's 800-244-0568. Anyone can call with a referral, and we will start the process through our intake office.
Okay.
If it happens to come from the hospital, then it's myself or the other nurses that do the liaison.
Yep.
We will get that process started and rolling. And within the 24-hour, we'll be contacting the patient and the families to let them know what the physician ordered and when we're coming in to see them so that they have a time frame.
That's great.
And it gives them a sense that somebody's coming and I'm going to get some help that I need.
And then once that first visit, there is, and I think you said it earlier, there's a comprehensive assessment that's done, right?
Correct. There are, again, as we mentioned earlier, regulatory requirements that any home care provider has to follow.
Okay.
One of those regulatory requirements is that at the initial visit, there be done, that's probably not good English, there should be done,
yes,
must be done, a comprehensive assessment. It comprises, a physical assessment from head to toe, looking at how patients manage their medications, how they ambulate, how they get up from a chair, how they get out of bed, how they are able to bathe and dress themselves. So by the time that initial assessment is done, there is very little that assessing clinician has not looked at and is not aware of how the person is able to do these tasks and if they're safe when doing them.
Right.
Based on that assessment then comes, all right, here are the problems that this assessment has identified. Now what will we do about those? And that's where other disciplines other than nursing might get involved. If you are assessing a patient and they are having difficulty getting out of a chair, walking across the room, then those are things that a physical therapist would address. If you find problems with bathing and dressing, doing light meal preparation, those are things that an occupational therapist would deal with. If you're having memory issues or difficulty expressing thoughts and ideas, those might be things a speech therapist would deal with. So we have a multidisciplinary group of professionals who can come into your home, work collaboratively with you, the patient, the family, and your primary care provider to try to develop strategies and mechanisms to address the problems you're having and keep you at home as healthy as possible and as safe as possible for as long as possible.
No, you know what, it really is, the more that the healthcare system shifts from an acute sort of hospital way of thinking to a safe and independent at-home way of thinking. I mean, home health care, we've been in business since 1946. Our various, offices throughout the southwestern corridor of Vermont have been in existence for 30, 40, 50 years plus. And what's amazing to me is just how really essential the world of home health care has become, because there is no less expensive way for these healthcare services to be provided. The statistics related to the cost of a hospital stay or a nursing home stay are I mean, it's
astronomical.
right, it's 20, 30, 40 times more expensive
Yes.
in those locales than it is at home. And the skill and the quality of the folks that we have that go into these people's homes, I mean, our patient outcomes are not just amongst the best in the state of Vermont, they're actually amongst the best in the entire country, are they not?
Yes.
Absolutely they are. We have been very fortunate to be able to keep a very well-seasoned, very professional staff that have been able to strive for a level of excellence in providing care in the home, and that statistical information that you referred to, outcomes, how does somebody get better from the time the VNA starts their services to the time they end their services. These are things that are publicly reported.
Yeah.
And we have been very fortunate. Last year we were in the top 100 agencies of over 9,000 agencies in the country in terms of the services we provide to patients in their homes. Pretty awesome when you consider this is a small
Yes,
community
absolutely.
in a small populated state in
Yeah.
a very large country.
Yeah.
So we have worked very hard at that and continue to do so. So I think that is a good indicator of the high quality services that we are able to provide people in their homes.
Yeah, no, I agree, and I look at the number of people's lives that we touch each year. I look at the quality of life impact that our staff have in people's lives every year, and you said it earlier, Beth, that we don't turn people away, and we are supported by the community, and our staff support the community too, and they're involved in a variety of community things. I'd like to thank both of you for being on the show today.
Thank you.
And it's so important, and I think it's important for folks to know that it really is an easy path to, even if you just simply have a question of should mom or dad or whoever be on home health care services, like you said, they could just call us at 800-244-0568. And they'll get into our intake department.
Yes.
And like you said, then our clinical staff go out there and begin the process. I'd like to thank all of you for joining us on Home Care Connection. I'm Harry Snyder, your host, and we look forward to seeing you next time.